Thank you. I would like to thank Jesper for giving this opportunity to talk to you today. In this presentation, I will tell you about the rescue carotid stenting in acute ischemic stroke at SS General Hospital. But before discussion about this, let me walk through some background information. As you know, left vessel occlusion account for approximately 40% in acute ischemic stroke, as demonstrated last trial. Among these, tandem occlusion present with the carotid occlusion, carotid artery surface stenosis and occlusion, together with intracranial occlusion on the same side. Moreover, tandem occlusion relate to the worst prognosis and difficult therapy approach. Intravenous thrombolysis fell up to the 80% in tandem occlusion case, while the mechanical thrombectomy is highly recommended in ASA guideline. Recent last study demonstrated the rescue carotid stenting. One study recorded good outcome that's about the 68% with stent compared to the 42% without stent. Another show good outcome, the 53% with stent versus the 45% without stent. Both are statistically significant difference. However, data in Asia is limited. A small series of just 17 patients have a good outcome of about 47%. This raises the question whether the rescue carotid stenting impacting on good clinical outcome. To realize the aim, how did we go about investigating about this? We applied the eligible and exclusion from the December 2020 to May 2024. Before procedure, we use loading duo antiplatelet. There are two main approaches to apply a tandem occlusion, such as distal to proximal and proximal to distal. The first, the distal to proximal, where we canalize the intracranial occlusion by Dotter technique after carotid stenting. The AF guiding catheter cross over the carotid occlusion like this figure of posterior circulation. Here is the short video of Dotter technique. Diagnosis Dotter and dilator Dotter may allow to strengthen the AF guiding catheter cross over the carotid occlusion easily. The second, the proximal to distal, where we canalize the carotid occlusion first. After that, mechanical thrombectomy applies in the intracranial segment. Here is the short video, the angioplasty to recanalize the carotid occlusion. Deflate slowly wider the AF guiding catheter to cross over the carotid occlusion. Post-procedure CT scan is aimed to hemorrhage after that, based on the ECAS2 classification. Now, let me show you the important finding in our study. Good outcome take up to about the 58%, and the death rate about the 17%. Several predictors, such as smoking, highness on mission, onset over 3 hours, prolonged procedural time, especially hemorrhagic transformation, longer ICU and hospital stay relate to the worst prognosis significant. Especially the rate of any hemorrhage was lower than the other study, possibly due to first maintenance of the systolic blood pressure after procedure about 110 and 120. The second, in addition to clinical assessment, the indication of recanalization based on the DWI MRI, which is highly sensitive, the CT scan. The third, the use loading duo on two platelets in our study was safe and lower than the other study. Our study have been published in the international journal. Collager can consult full detail in with link below. A 67 years old present with the right hemiplasia onset to our MRI recorded the left of the carotid occlusion. We applied firstly the Dotter technique to give the AF guiding catheter crossover the carotid occlusion to aspirate the thrombus in intracranial segment. After waiting 5 minutes, carotid artery reocclusion. Rescue carotid stenting were deployed this side. The CT scan, no hemorrhage, and improvement of NIS after that. I think our discussion presented so far can allow me to give the essential point. The first point, based on the protocol, experience, and available device of each hospital. Following point, to allow to make important decision to get permanent recanalization. And finally, I think I would like to conclude my presentation by expressing my appreciation to these colleagues in this line. Thank you for your attention. I'm happy to take your question. Thank you.